now in 2017, where are we in terms of disease prevention? How do we prevent this disease in the first place? Pre-exposure prophylaxis, how do we deal with that?
So we spent a lot of time with voluntary counseling and testing, invested billions of dollars in the richest country in the world, and the number of new infections is estimated to be essentially unchanged in the United States over the last decade or more.
So you're saying it's a bust?
Well, you could argue
It's
maybe it
starting
had
to
been.
come better. It's starting to come down.
Yeah, but you could argue
down.
it could have been a lot worse had we not made the investment.
Okay.
But it wasn't enough.
Right.
If we're still having 40 to 50,000 new infections a year. So it wasn't enough. So people started looking at biologic ways to manage this that doesn't require entirely people changing behavior. So we always look to vaccines, and so far vaccines have been a bust.
Okay.
Your taxpayer dollars at
So
work.
then the next big step, and we actually learned this over 20 years ago in preventing pregnant women from transmitting to their baby, is using antiretrovirals.
Okay.
And I think the two big advances that have had a big impact globally now is the recognition that when we treat somebody with HIV and suppress their virus, the risk of them transmitting to their partner is extraordinarily small.
That's because the actual particle count is nil.
Exactly.
Right. Precisely.
Exactly.
Right, sure.
So that's been by far the biggest advance in prevention. I mean, it is virtually 100% protective based on the data that's available if somebody's on therapy and their virus is suppressed.
And in fact, in several cities where a high proportion of people are on therapy, the number of new infections has dropped.
Okay.
So that's
one.
population.
Right.
So let me get
San
another way.
Francisco being, I
One of
think,
the
the most
proposals.
notable.
London
cases.
and New York. and-
Let's hit a couple of quick bullet points. Women trying to conceive, can they be prophylaxed? Oh.
So I think there's two ways to look at this. So you're assuming now the male partner is HIV infected and the woman is uninfected.
Okay.
And they're trying to conceive and have a biologic child. There's
Yes.
lots of pieces to this, right?
Yes.
Because there are alternative means in which one could accomplish this feat. But to have a biologic child, we're talking about
old-fashioned way.
Yeah, you want to do it the old-fashioned way. So, the first step, based on the data that's available, is if the male partner's viral load is undetectable and has been for at least 6 months, the likelihood of them transmitting to the partner should be virtually zero.
Okay. So the bullet point on that is you treat the male partner.
That's the most important.
By far.
What about unborn children, prophylaxis?
Well, just the prevention of HIV from mother to child. We know how to do that. You treat the mother.
Okay.
Treat the mother. Treat the mother. Treat the mother. And in in I don't know what it's like in Massachusetts or Pennsylvania, but in North Carolina, maybe one transmission a year or two in the entire state
that's
from mother to
remarkable.
child. I mean, it's gone away. Pediatric HIV is
It's
done.
amazing.
I would like to point out that when I said it was a bust, that was before you said that.
Right.
That's huge.
Yeah, I mean, people who specialize in pediatric HIV need to find a new specialty.
The whole network needs to find a new thing to do.
I will say one thing is still an open research question, is that what is the safest treatment to give the pregnant women?
Right. That's not
And
clear.
that we can prevent transmission of HIV, but the babies born to HIV-infected moms who don't get HIV themselves appear to have health issues, and we're not sure whether they're getting some toxicity from the drugs or who knows what. So that's still not an answer.
But
And then
can we?
very briefly,
It's really
'cause I have
important.
to- I have one
I
more.
know
Go
it's brief, but we pre-exposure prophylaxis, PrEP. We just have to mention PrEP because if a lot of people that are out there listening to this are primary care doctors, what Eric was trying to say about using antiretrovirals in those very high-risk groups that Ian mentioned, the men who have sex with men, injection drug users, which is going way up, right? I mean, I was just on service. All this, endocarditis again, that's like back in the battle days. Just remember PrEP. People, remember PrEP, right?
Okay.
And that's for the masses, right? So first I talked about what the 1.2 million in the United States can do to prevent from transmitting to their partners. PrEP is really for the millions and millions of uninfected people that allow them to protect themselves.
And it's a reason why people may want to volunteer and get tested.
I got it.
Because if individuals know that they're at risk for acquiring HIV, and if they're aware that there's a way that they can prevent becoming infected by taking a pill a day,
Right.
then that's incentive to be tested, to find out you're negative, and then to request PrEP.
Okay, what about post-exposure prophylaxis? And this is of particular interest, of course, to healthcare providers, but anybody who suddenly finds out, oh my gosh, I was exposed, what do you do?
So we give 28 days, 4 weeks of therapy. in the occupational exposures, it makes sense. It probably works. We give it also to people who have, for example, sexual assaults. In that setting, I think a lot of what we're doing is just trying to do something rather than nothing, because often we don't know the source patient has infection at all. So there's, I think, a tremendous amount of over-treatment for post-exposure prophylaxis. Nonetheless, we do it. It is endorsed in the guidelines, and it's probably one of the reasons why, at least occupational exposures, there has not been occupationally transmitted HIV in this country for decades.
Decades.
right?
Yeah.
And it's the advance is that now it's safe and well tolerated.
Yeah.
You know,
Used to be.
20 years ago, you're taking cytovidine,
Yeah.
AZT every 4 hours. You're vomiting, and,
Right.
and now it's like it's really.
So all my
very
residents who
straightforward.
get a needle
Yeah,
stick and they panic,
right.
I can quote
Yeah,
them, you.
yeah.
Yeah, you can say there has not been an occupational exposure that has led to HIV acquisition in the United States in decades.